As I've shown in my two previous videos, hip flexor tightness and psoas tightness or overactivity has very little to do with the muscles themselves. It really all goes back to the brain. And when those hip flexors are overused, it's usually because of, or they're tense, it's usually because of one of two things: postural instability or non-diaphragmatic breathing. And the reality is they kind of go hand in hand. And the biggest threat, and this is I'm going to show plenty of evidence of this in this, I'm going to cite studies and research. The biggest threat to postural stability is actually the stomatognathous system, the jaw and the teeth. And this video is going to show why. The vestibular system is your upright balance. It's reflexive. It just runs in the background and it's taking in all this visual information, information from the ground, sound. So what you see, the frequencies of light, the frequencies of air molecules hitting your eardrums, the frequencies of the ground underneath your feet alternating as you move forward. That's what your brain responds to. That's all it has to go on. Your brain is blind. It's integrating these frequencies to produce the correct muscular output. And this is all vestibular in nature. When that vestibular system gets threatened because of malocclusion or a jaw that's mispositioned, it shifts your body weight. It puts you in a position of tension, which throws off your frequencies, and at that point your hip flexors or your psoas will become overactive. But remember, the psoas is not the issue, the hip flexor is not the issue. The issue is what the brain is perceiving and the output that it's then producing off of that incorrect input. In postural restoration, the normal underlying pattern of right dominance is called the left AIC, right BC, right TMCC pattern. At the pelvis, it just means the left side of the ilium comes forward. The right side is usually back, or it can come forward also, but not as far forward as the left. That usually results in an overall orientation of the pelvis to the right, which shifts your center of mass to the right. This is completely normal. Again, it's because, as this channel has stated in my 300 videos or so, of this inherent right dominance built into us because of the bigger right diaphragm, and a visual system that processes, or a brain that pays attention more to the right side of our visual field than the left. So our brain is overprocessing things on the right to begin with. This is completely normal asymmetry and not a problem until that normal asymmetry becomes abnormal asymmetry. The biggest driver of abnormal asymmetry and pain patterns that people cannot get out of, from my own 10 years of experience and just PRI in general, postural restoration in general, this is what's taught and this is what pretty much all PRI practitioners come across. The biggest driver of pain and patterns of incorrect compensatory stability that people cannot get out of is coming from the neck, but really the stomatognathous jaw-teeth system that's influencing that neck. So when someone's pattern is normal just because of what's going on from the neck down, like I showed, I can turn off people's hip flexors and their psoas muscles just by having them walk to music. Why? Because it's regrounding them. They're over on the right side, but they don't even realize it. So they're spending too much time on the right foot, not enough time on the left foot. But their brain will synchronize with the beat. As long as the heels hit the ground with the beat, that will alternate your weight from side to side evenly, so that your asymmetrical walk becomes more symmetrical. Remember, you don't know you're walking off beat. You just walk. But in a pattern, when the pelvis never turns to the left completely, you never go from right to left efficiently or completely because you're stuck more on one side. Your brain will entrain with the music. Your internal metronome is broken. It's not working anymore. So your brain will entrain with the music, and this is all done in Parkinson's research. You can look it up. If you think that's BS, because a lot of people are writing in these comments that they think it's BS, look up Parkinson's research and gait and music. It all comes from there. And there's tons and tons of research on auditory system, music, and the motor output that our body produces. At any rate, so when people have nothing going on above the neck, I can turn those hip flexors off. As long as they can get their heels to hit with the beat, those hip flexors will inhibit, release, turn off. They then need to be retrained. You still need to retrain postural stability, but in terms of releasing an overactive psoas and hip flexor on the left that's holding your pelvis in this position, very simple. Again, the problem that I showed next in these next two videos is when people have something going on in their cranium, and this is where the research is going to come in, because this is where people really don't believe it. I don't even know why, but they really don't. and they get very upset about it. But at any rate, when there's something going on up in the cranium, that takes away ground sense. You become ungrounded because the neck becomes so overactive and your big neck muscles pull your chest up. You become a neck breather. And these neck muscles, the scalenes and the SCMs, with every breath you take, they pull you up away from the ground. So you're constantly being lifted. If that neck tension can't decrease, your rib cage can't come down, you can't get your pelvis back into a normal neutral position, and you can't ground yourself. Sounds very abstract, I know, but that's really what happens. So you have an ungrounded system. And what keeps the neck overactive, and when you have that ungrounded system, walking to the music won't really work that well because this sensory system up here is what grounds you. Your feet don't ground you, ironically enough. Your feet will be useless to you if you have something going on up here. Your sensory system, your visual system, your auditory, your vestibular, and your stomatognathtic, jaw and teeth, are what allow you to ground and make your feet useful, and you'll actually see evidence of this in the studies that I show. But just remember, in videos like these, where I'm showing how I manipulate someone's bite and how I manipulate someone's vision to turn on or turn off reflexively their hip flexors and psoas, that's because I'm manipulating their sensory input in their mouth or with their visual system. I'm manipulating it so that I'm giving them what they lost. Like the gentleman with the tongue depressor, he lost his molar sense. Molar sense is huge, as you're going to see in the research. Now, the visual, I don't really have evidence of that because you're just not going to find it. It's just an observation. Now, the idea that you have a fixation eye that likes to fixate on something, completely normal. And it turns out the left eye is what you find. The left eye tends to fixate in the distance while the right eye tends to fixate kind of up close. But we need those eyes to alternate between near and far to get a full panoramic three-dimensional visual system that's perceiving peripheral space on the right and on the left is where we lose it, and that's what I'm showing in that video where I had him looking at the pole and then looking at the distance, looking at the pole and the distance, and then with the glasses all I did was take away his left eye distance, and then his brain had to pay attention to the periphery, so again his hip flexors relaxed, because those hip flexors were being used as a way to stabilize a system whose vestibular system, because of the visual input and the jaw and the teeth, and maybe the inner ear, you don't know because they're so interconnected, has been thrown off. So when that system's threatened, hip flexors turn on, neck flexors turn on, and you're reflexively tight. When I manipulate those senses, the body relaxes because I'm giving back to the brain what it lost. So I just went through the PubMed database, and so here's just a sampling, and there's a lot of it. Here's just a sampling of the linkage between postural stability, how you stand, how you move, and your occlusal, your jaw and your teeth. And here's the first one, troika of posture, occlusion, and airway. I mean, I'm not going to go through all of it, but there you go. And they're talking specifically the relation between the maxillary and mandibular permanent first molars. Posture is dictated by the existing occlusion. It says it right there. Good posture means spine is neutral. You cannot get neutral if your occlusion is too off. There is probably some degree of asymmetry that's allowable, no doubt. Just because your teeth may not sit perfectly doesn't necessarily mean that your postural your stability will be threatened, at least not at this point in time. So I'm not saying it's for every single person. For some people, and they tend to be the hardest cases to work with. Then at the bottom, the results in a cant of the maxilla, which is when the jaw is on a bite, a diagonal, like the teeth and the jaw are kind of diagonal. The results in a cant of the maxilla leading to the body posture condition called scoliosis. So I think when people get diagnosed as having adult scoliosis, or not adult scoliosis, I'm sorry, when they've developed in adulthood, they've developed slight scoliosis, they could be looking at, or the doctor not knowing what he's looking at, he sees a curve in the spine, but he might not notice a canted jaw position. But that jaw can get canted because of hyperactivity of the neck. So again, these patterns, this hyperreflexivity, can cause what we're talking about. Second one, relationship between unilateral posterior crossbite and human static body posture. Conclusion, The presence of the unilateral posterior cross, so a crossbite in the back of the teeth, affects static body posture, but the side of the crossbite, whether it's on the right or the left, is not related to the direction of effect on, it doesn't matter which side it's on, just crossbites are bad. I am a classic crossbite. Crossbites are bad, I know this, and you're gonna even, well, I'll get to the next study after this, but that's just showing, this is why I care so much about teeth, and when I do, someone who comes to see me, the first thing I'm asking for is, let me see your teeth. What are you feeling? What are you sensing? For that exact reason. When I do online stuff, half of my questionnaire is devoted to teeth, jaw, and vision for this exact reason. Because when you have something like this going on, all the PRI techniques in the world might not change a whole lot because the whole system is being reflexively tightened up because the system is still threatened. The vestibular balance system is still threatened because of something that's going on through the jaw and the teeth. If you're still with me and you like this video, could you like it, comment, share, or subscribe? I'd appreciate it. Third, correlations between dental malocclusions, ocular motility, and convergence disorders. I definitely had a convergence disorder, and I'm farsighted, so I always struggled to converge my eyes. I overworked my eyes. Dental malocclusion. The purpose of the study was to analyze the association between dental malocclusion, ocular motility, and convergence disorders in growing subjects. Now, they were doing it with kids, but that's when most of this stuff actually does start occurring. And that's what they see. Ocular motility defects had a significant greater prevalence in subjects presenting with unilateral, crossbite, and midline deviation. I don't like to see midlines to the right. So I don't want to see the midline of the bottom teeth to the right of the midline of the top teeth, nor to the left. I'd prefer to see it completely aligned. But it's worse to the right because that usually indicates a twisting or a torquing of the cranium that really shouldn't be there, which then messes up how the head is sitting on the neck. It's kind of complicated, but again, it's right here. It's in the importance of role of orthodontic diagnosis among interdisciplinary treatment in growing children should be recognized. If someone has a torqued cranium and a jaw that's offset, that's going to affect how they move. That will affect their posture. Open bites, whether it's in the back or the front, might force you to start walking on your toes. Toe walking is not a good thing. If you see a kid that's walking on their toes, you got to get them checked out. They may develop oral cavity issues, or that oral cavity and improper breathing, tongue position, swallowing, it's all tied together, may produce that toe walking. Either way, it's not a good thing. Plantar pressure variation. So plantar is the surface, the undersurface of the foot. Plantar pressure variations induced by experimental malocclusion. So they created, if you can read this on your own, they created an artificial malocclusion on the right side of the mouth. And when you ask most people, when I ask them the question, do you sense the right side of your mouth or the left side of your mouth, or where do you sense your mouth most? Most people will say the right side, and that's a normal answer. And what you see is when they did that on the right side, when they gave that person more right side tooth awareness, the external, underneath the outside of the right foot, the pressure increased. That's what you find all the time. Because when people say, I feel my right molars more, they'll usually, and when I ask where on their feet that they're feeling the ground underneath their feet, they're almost always saying the right heel or the outside of the right foot. Because when you bring those molars together on the right, and the next study is going to show this, when you bring your teeth together on one side, the body sways to that side. When people are over-sensing their right molars, which is way more common than the left, you know they have overactivity of all this musculature. Well, no, I can't say that. You know they're over-sensing their right teeth, which means they're over on the right side of their body, and their right foot is living in a state of supination. And the left foot is living in a state of pronation. You see it, 80% of the people that I work with have this finding. A more supinated right foot and a more pronated left foot, and they're going to sense their right molars more than their left. Why? Because they're on the right side of their body. They don't know that, but they are, and their jaw position has just adapted to stay centered. And that's why they feel that. All right, so this next study from Japan shows that, and I don't have it in front of me right here, I'm just going off memory, but I will include a little photo in the video. When you lose sense of one side, your body shifts to the other side. So that's no different than if I bring my teeth together on the right, I lose my left side sense. That will shift my body to the right. But if I bring my teeth together on the left, I lose the right side support, and I go to the left. That's alternating activity. That's rhythm, like rhythm, chewing. Chewing is rhythmic. Most people chew on the right side. Not surprising. Most people stand on the right side. You got a bigger right diaphragm. Your brain is paying attention to the right side of your world, visual field, more than the left. Not surprising. Your right ear and your left ear are asymmetric. The right ear hears a little bit faster than the left ear because of how this whole thing is set up. Right side dominance is the norm. So again, this is just showing the same thing. So with the video, with the tongue depressor on the left, if you can't sense your left molars, your body can't sway to that side. Molars and heels, left heel, left molar. If you don't have left molar sense, you'll never get left heel sense. And if you don't have left heel sense, which is really left ground sense, you'll never get your left hip flexors and psoas to turn off. You can't inhibit it in order to get your left hamstring because you're unstable. So you're not going to be able to bring your pelvis back on that left side because without that left molar sense, your body will not sway to the left side. And if you can't sway to the left side, you can't ground yourself on the left side. So that's the perfect study to show, or all these studies are to show what I did with the tongue depressor this is normal. This is normal stuff. We just read the research. It's already there. It's not a trick. And then in regard to the dental splints, I'm not selling them like you're just selling splints. No, we weren't. We were explaining why they're used in posture restoration. And here's a study that proves exactly why it's done. And by the way, this is a new study. PRI, the founder of PRI, has been doing this for 30, 40 years, okay? And as have other dentists, because splints are known to have a lot of benefits. But here's one: improvement of cervical spine mobility. I say that specifically in the video. How many times? To relax the neck. That's why they're used. Improvement of cervical spine mobility and stance. Can you stand on your right leg? Can you stand on your left leg? If your neck cannot move, you can't get to either one. If your jaw is locked up because of malocclusion, your neck doesn't move, you can't get onto your left leg or your right leg. So your left stance is off and your right stance is off, even if you're on your right side. Doesn't mean you're using the right side appropriately. So improvement of cervical spine mobility and stance stability by wearing a custom-made mandibular splint, the exact damn same thing. I get worked up a little bit when people ignorantly just are ignorant. Oh, but anyway, here we go. Made in male recreational athletes. The results: the cervical spine mobility increased significantly by wearing the splint regarding rotation to the left and right and lateral flexion to the left and right. Wearing the splint reduced the area of sway deflections, whatever. The COP trace was reduced. Center of pressure trace was reduced in the sagittal plane by approximately 8.2% in the right single leg stance. The major findings seem to demonstrate that wearing a splint that keeps the jaw close to the centric relation, which is what we want, someone's jaw that's shifted over to the right or to the left has lost centric location, which means neck muscles have to be over. You can't have a jaw to one side or the other and have all this neck muscle, which is connecting to the jaw. It can't be balanced. And that's the problem. When it's unbalanced, all the forces on the rib cage and the thorax and then all the way down to the pelvis are also going to be unbalanced. And again, hence the hip flexors and the psoas kick in. So the splint turns off hip flexors because it balances neck muscle forces. The major findings can demonstrate that wearing a splint that keeps the jaw close to the centric relation may increase the cervical ROM and may improve balance stability in male recreational athletes. So yeah, there you go. That's what we do. That's what PRI does. That's why they're used. This stuff is not being made up out of thin air. It's in the research. Go onto PubMed, keep researching. It's already there. Now, just a few images to kind of show what to get a better understanding of the anatomy of this area. So here's the vestibular apparatus. So obviously you see the eyes, but the red arrow is pointing to the semicircular canals, the vestibular, the inner ear area. So you can see if your head is tilted in one direction or another, you've got a visual system that has to kind of right things, your head, but also these semicircular canals that are paying attention to rotation, forward, back, side, rotation of the head in these, I think it's 6 different, they do it like pitch and yaw. I can't even remember all of them, but basically, but if you've got a head tilt, because your right shoulder's lower and you have to side bend your neck and twist the neck to stay straight, your brain is already perceiving things out of order, let's put it that way. It has to somehow make sense of this altered visual environment, but it's going to maintain that steady line of visual sight, things have to stay tight, and you're not going to move from side to side very effectively. And that's why the right TMCC pattern, which I'm going to show a little bit more of, is can be so problematic if it's being driven by something going wrong with the visual system or the teeth and the jaw. If it's just breathing related because you became a neck breather, that's not really that hard to deal with. But when something goes wrong with the visual system or the jaw and the teeth or the semicircular canals, which does happen, but they're not usually coming to me for that because they usually can't get out of bed because they have vertigo and all these other types of issues. That can really affect what we're talking about. So that's the vestibular apparatus. So now what I did was I added the temporal bone and the sphenoid bone. Oh, and the jaw. So you can see that the jaw, the mandible, and I also added the molars and the canines. So the mandible, look how close it is to the inner ear, to that vestibular apparatus in that inner ear. Then when I add the temporal bone and the sphenoid bone, the temporal bones are here. They're the T and the TMJ. So the TMJ, the joint, is the intersection of the mandible and the temporal bone. And that temporal bone is directly connected to the bone right behind your eyes, which is the sphenoid bone. And the sphenoid bone is the sphenoid bone articulates or intersects with lots of cranial bones, but also the maxilla, so that the top of your mouth. So when teeth are not positioned properly and they cause the jaw to deflect in one direction or another, or that it causes hyperactivity of one side or the other, the muscles, and let me just show some of those muscles, and in particular the temporalis muscle, because this is the one that we're really going to deal with in terms of this right TMCC pattern, right tempomandibular chain of muscles. That temporalis muscle is a jaw elevator. And the molars and the canines, so remember the pelvis has to alternate. So the iliums themselves go into internal rotation and external rotation. On the left side, it's usually stuck in a state of external rotation. On the right side, it's usually stuck in a state of internal rotation. This is the left AIC pattern. Well, the same thing happens in the cranium. These temporal bones have small amounts of movement available to them. And apparently that's finally being accepted in the medical world and the dental world. It's been known to osteopathic doctors for 100 years. It's been known to cranial sacral therapists for a heck of a long time. They have movement. Otherwise, your cranium would just break because it would be so... There has to be movement. There has to be movement to the thing. Otherwise, you wouldn't be able to move, period. And that's the problem. When the cranium gets locked up, you can't move. And nothing locks up a cranium faster than a jaw that's not positioned properly. But at any rate, the temporal bones... I'm not going to use that. The temporal bones need to work just like the pelvis. And what you find is normally, the left temporal bone gets stuck in a state of external rotation, just like the ilium. The right side gets stuck in a internal rotated state, just like the right ilium. It's just pelvis, cranium, temporal bones. These temporal bones have to alternate appropriately for the jaw to alternate properly as you chew, and for shift of the body, because otherwise the neck stays overactive. So if you don't have a molar, so in reality the molar has an internal rotation effect on the temporal bones. So through the temporalis muscle. So when the molars hit, the temporalis muscle will activate, and the masseter, and probably others, and the pterygoids, which I'm not showing right now, but the pterygoids are really important. So when the molars, the left molars will have, when you bring your teeth together on the left, together with the pterygoid muscles, which I've shown in other videos, they will tend to take the left temporal bone and bring it in. The canines externally rotate. So that's why you need molars and canines to have the internal rotation, external rotation, internal rotation, external rotation. Now, it doesn't work like you're walking. It's a different mechanism, but the model still works. So we call it wobble. The temporal bones have to wobble, but they can only wobble if they have a force that will internally rotate them and a force that will externally rotate them. And that turns out to be the molars and the canines. And of course, so if you don't have molar and canine appropriate contact, the temporalis muscle will get all thrown off, and the pterygoid muscles will get all thrown off. And these are the muscles that push your jaw from side to side as you chew. But they also allow your head to rotate effectively on top of that neck. So the splint is to allow this system to become normal again for people whose craniums and stomatognathic systems have become abnormal. And then just the last one right here, you can see the occiput, the back of the head. Right? So the back of the head, you can see the temporalis muscle. So this temporal bone, the temporal bone attaches to the occiput, so that the position of the temporal bones will influence the position of the back of your head and how the back of that head sits on top of the atlas, which is the first cervical vertebrae. Osteopaths and craniosacral people, they consider, and probably there's a type of chiropractor, NUCA, they work on this area, so they know that this intersection of this cranium, this occiput, the back of your head, on top of that first cervical vertebrae, is pretty much the most important joint in the body, because that's where the brainstem goes through also. There's a foramen magnum created right here. The temporal bones, so here, the sphenoid bone, the temporal bones, and this occiput, that intersection creates this frame. That's where your brainstem goes through. So when the cranium is torqued because of this stomatognathic system, the brainstem can be impinged. So bad things can often, you don't want your brainstem impinged, because this hole may start to close on one side more than the other.